Hi guys, welcome back to the Prepladder NEET SS. This is Dr. Patil here, and in this video module we will be addressing chronic hepatitis. First, we will take a little broader look at what is chronic hepatitis. We will understand its definition, common and relatively less common causes, and a basic approach to chronic hepatitis. Now we are doing this before we go on to discuss specific causes for chronic hepatitis, mainly focusing on viral hepatitis B and hepatitis C. There's an important reason why we are taking this approach of a general overview before we start with specific causes. The reason is most of the times viral hepatitis gets diagnosed when we incidentally detect LFT abnormalities. Right? When we do LFT for some indications, we notice that the AST, ALT is elevated or other components of LFT are abnormal. And that is when we start investigating. And we might end up diagnosing it as chronic hepatitis first, and then we have to evaluate for the cause for chronic hepatitis. And then comes the question of management. So we should have a brief overview of an approach to chronic hepatitis. So that is why we will take an overview and then we will start with specific causes. Okay. So when I say chronic hepatitis, right, what do you mean by that? When I say chronic hepatitis, I mean I'm talking about a condition where there is inflammation of the liver. But when you say chronic, you have to define it precisely, right? So inflammation of the liver, which is persisting for more than 6 months, we will be calling it as chronic hepatitis. Inflammation of liver persisting for more than 6 months, we will call it as chronic hepatitis. So 6 months is the number to remember. Okay. Now, how do I get to know that there is inflammation? What is the evidence of liver inflammation, right? So the evidence stems from either LFT abnormalities or liver biopsy suggestive of inflammation, right? So what LFT abnormality? Obviously, when I say LFT, I'll be mostly looking at transaminases, right? AST and ALT. Now, if there is an examiner asking you which one will you specifically consider for a diagnosis of chronic hepatitis between AST and ALT, what should be your answer? Obviously, ALT, right? ALT is liver specific, right? ALT is a liver specific transaminase. That means it is expressed only by hepatocytes. Right, so it is expressed only by hepatocytes. So when ALT is elevated, it means hepatocyte injury is there, right? That means there is an inflammation going on. But AST is not liver specific, right? It is not liver specific. That means it is expressed in other tissues, right? So what are the other tissues where AST is expressed? The other tissues where it is expressed include number 1, RBCs. Okay. Number 2, muscles, right? I'm talking about skeletal muscle cells. And number 3, cardiac myocytes or cardiac muscles. Okay. So AST can be elevated when there is hemolysis, when there is rhabdomyolysis, and when there is myocardial infarction. So in all these circumstances, AST can be elevated, right? Apart from hepatitis. But ALT will be elevated only in cases of hepatocyte injury. Acute or chronic, we have already known, right? When it is of more than 6 months duration, then we will call it as chronic hepatitis. Okay. Or the evidence can stem from the presence of inflammation evident on the liver biopsy. Okay, so this is a basic definition of chronic hepatitis, right? Liver inflammation persisting for more than 6 months. Most cases we get to know when we say that the AST or ALT are elevated for more than 6 months. Okay. Now with this definition, let me go to the causes for chronic hepatitis. And when I say causes, let me first say common causes and then we will talk about rare causes. And among the common causes, the question they might ask you is what is the most common cause? The most common cause is no longer viral hepatitis. Right? Viral hepatitis is less common of a cause nowadays in comparison to non-viral causes for chronic hepatitis. And among them, we have most importantly, non-alcoholic fatty liver disease, right? Which leads to inflammation. Then we will call it as NASH. So non-alcoholic fatty liver is the most common cause for chronic hepatitis, right? So what other common causes we should be aware of? Yes, alcoholic liver disease or alcohol associated liver disease or alcohol related liver disease, whatever terminology you follow. And then we have viral hepatitis, right? And when I say viral hepatitis, I'm mostly talking about hepatotropic viruses. Yes, there are also non-hepatotropic viruses which can cause chronic liver inflammation, which we have discussed in a separate tiny video module. And when I say viral hepatitis, or like specifically hepatotropic viruses, what are the viruses that can cause chronic infection? B, C, and D. And we all know that D is a dependent virus. It is dependent on B. So D infection can only happen when there is a pre-existing B infection, or B and D are causing a co-infection. Okay. Now, what are the relatively less common causes? I shouldn't be calling them as rare causes, but relatively less common causes. Okay, so the first thing I would think of among the less common causes is autoimmune hepatitis. A very important topic from the exam perspective, right? Differentiation between type 1 and type 2 autoimmune hepatitis. Yes, we have discussed that in the detailed video module. Autoimmune hepatitis, drugs. A long list of drugs can cause chronic hepatitis. Again, we have discussed drug-induced liver injury in a detailed video module separately, right? So please go through them. Okay. Now, after autoimmune hepatitis and drugs, are there any genetic or metabolic conditions that can cause chronic hepatitis? Let me give you a clue. This genetic condition can also cause fulminant liver failure and is a priority indication for liver transplantation if this genetic condition leads to fulminant liver failure. Right, I'm talking about Wilson's disease. Wilson's disease can cause. Then also hemochromatosis. Hemochromatosis can cause chronic liver disease. Okay, anything else we can think of? We have already spoken about autoimmune hepatitis, drugs, Wilson's disease, hemochromatosis. Okay, I think that's like kind of a simplistic list of causes for chronic hepatitis. This list is not exhaustive. Lot of diseases can have liver involvement, right? Lot of genetic conditions, lot of storage disorders. So it will be like beyond the scope of this discussion, but the key points you need to remember we have already covered. Okay. Now after the causes, let me take you through a quick overview of the clinical features. Okay. Now we have to understand that most cases are diagnosed incidentally when we notice LFT abnormality. That means most patients are going to be asymptomatic, right? So majority patients are likely to be asymptomatic until and unless the chronic hepatitis is persisting for several years, and that has led to hepatocyte liver fibrosis, and then development of hepatocyte dysfunction and development of portal hypertension. That is where most of the patients start showing up clinical features there. In the interim period, when there is an active hepatitis going on, but there is no established cirrhosis yet, those patients might have some vague symptoms like fatigue, myalgia, or malaise, or a mild low-grade fever. Those are possible symptoms, right? Majority are asymptomatic at the time of diagnosis, right? Patients may have vague symptoms like myalgia, fatigue, malaise. Okay, so these are like common things. But once the condition progresses and patient develops cirrhosis or fibrosis starts developing, right? And there is hepatocyte loss, right? Hepatocytes are significantly reduced. We start seeing clinical features, right? So what clinical features we will be seeing? We will be seeing clinical features due to hepatocellular dysfunction or failure of the hepatocytes, and features due to portal hypertension, right? So what are the features that are related to hepatocellular dysfunction? I can see patients presenting with jaundice, right? Then I can see that these patients might develop palmar erythema. They might develop spider angiomas. They might have loss of axillary hair. They might have testicular atrophy. And due to portal hypertension, they can have esophageal varices, which can lead to upper GI bleed, which might manifest as either melena or hematemesis. Okay, and portal hypertension might lead to development of ascites. There would be risk of spontaneous bacterial peritonitis, and apart from these, because of the reduced production of vitamin K dependent factors, right, especially advanced cases might develop coagulopathy, and because of the toxin accumulation and ammonia, these patients might also develop encephalopathy. Right, once they develop coagulopathy and encephalopathy, that is the point where we say that patient has got liver failure, right? Liver failure. And when from the onset of jaundice to the development of liver failure, if it is taking more than 26 weeks, we will call it as chronic liver failure, right? When it happens within 26 weeks of the onset of jaundice, we will call it as acute liver failure, right? Okay, so these are the clinical features we can anticipate. But please remember that most patients are going to be asymptomatic. They will be diagnosed at that stage, and it's our duty to manage them efficiently so that they don't progress to develop a stage of fibrosis and hepatocyte loss, so that we will not be seeing them with all these clinical features. Okay, now with this backdrop, let us look at how do we approach when we incidentally find out that patient has got LFT abnormality and it is of chronic duration, right? So approach to chronic hepatitis. Approach to chronic hepatitis. So first point is about the diagnosis of chronic hepatitis, right? That's the first step. How do we diagnose chronic hepatitis? We will diagnose chronic hepatitis when ALT is elevated for more than 6 months. I've already told you ALT is liver specific, right? Or there is liver biopsy evidence of inflammation, if you had already got the liver biopsy done, which is persisting for more than 6 months. Okay, now the diagnosis of chronic hepatitis is done, right? So we have made a diagnosis of chronic hepatitis when we proved this chronic hepatitis. Next question is, what is the cause, right? Etiological assessment. The step number 2 is etiological assessment, and obviously we should first look at or think of the common causes, right? So what are the initial investigations you would do? Definitely, like many causes like non-alcoholic fatty liver disease or even alcoholic liver disease, the diagnosis depends on ruling out viral hepatitis. So we definitely need to do the serological markers. So what are the serological markers we will be doing? For the hepatitis B, I would require HBsAg and anti-HCV, right, IgM as well as IgG, right? Why do I need HBsAg? HBsAg is a pointer towards hepatitis B infection. When HBsAg is positive, patient has got hepatitis B infection. Okay, then why do I need anti-HCV, IgM and IgG? Right, now this will help me to understand whether the patient has got an acute hepatitis or chronic hepatitis. So if it is acute hepatitis, anti-HCV, IgM will be positive. It might or might not have IgG positive depending on when we are testing it. But when it is chronic hepatitis, IgG will be positive and IgM will be negative. Normally what happens is IgM is secreted. Soon after, IgG is also secreted, but the IgM will be lost. IgM will not persist. IgG will persist. IgM will not persist beyond 6 months. So if you have IgM negative, IgG anti-HCV positive and HBsAg positive, that is the case of chronic hepatitis, right? Clear? So this will be positive, IgM will be negative and HBsAg will be positive. So if all these three are like, if this is met, we will be calling it as chronic hepatitis B, right? Then for C, what we need to do? For hepatitis C, I would require anti-HCV antibody, right? And the method of doing it is enzyme immunoassay. Right? If it is positive, it indicates that patient has got chronic hepatitis C infection. Obviously, it should be persistent for 6 months, that which we have already understood, right? Okay. Now, what other investigations I would require for like other causes we have discussed, right? Now, non-alcoholic fatty liver disease is a diagnosis of exclusion. Alcoholic liver disease history is relevant, but still we need to rule out viral hepatitis. Okay. Now, in case when the patient is not alcoholic and it doesn't look like it is the fatty liver, you need to start thinking about other causes, right? So among the other causes, autoimmune hepatitis is one, drugs is one. Drugs obviously dependent on history. If you don't take a good history, you might miss the diagnosis. Autoimmune hepatitis, you might need a laboratory support. Wilson disease and hemochromatosis, most of them will have other non-hepatic clinical manifestations. So diagnosis may not be very difficult, but still we might require a plethora of investigations. Okay. So what else you would like to add? What are the investigations that you would do for autoimmune hepatitis? Antibodies, obviously, right? So I would require ANA, which is typically seen in type 1 autoimmune hepatitis. And what is the antibody that we would do for type 2? Right. Anti-LKM1. Anti-LKM1 antibody. Anti-liver kidney microsomal 1 antibody, right? So these antibodies would suggest autoimmune hepatitis, right? This would suggest HCV, chronic HCV infection. This would suggest autoimmune hepatitis. And based on the cases, you might require additional investigations, like for diagnosis of hemochromatosis or for the diagnosis of Wilson disease. You might require additional investigations. Okay, so this will be our approach. Now, we have done the investigations, so we have made sure that this is a chronic hepatitis. We have evaluated the cause and we know the cause now, right? What would be our next step? So step number 3 would be to focus on or try to identify whether there is fibrosis or not. Assessment of fibrosis. Okay, how do we assess fibrosis? Obviously there are invasive and non-invasive tests, right? Invasive is biopsy. Nowadays not routinely performed. Previously it was like strongly pushed for, but nowadays not routinely performed because we have very effective non-invasive tests. Again, not getting into the details, we have discussed the details of non-invasive tests in the non-alcoholic fatty liver disease. So let me restrict to only listing some of them, right? Okay, the simplest one I can list is APRI. Okay, apart from APRI, there is FIB4 test, and then we have FibroScan. And we can also think of MR elastography. So I can go on listing the investigation that can help non-invasively assess the degree of fibrosis. But like these are the common things that we need to remember. Okay. Now we have done the assessment of fibrosis, so we know where do the patients stand and how is his likelihood of progression to cirrhosis and what is his likelihood of or risk of developing hepatocellular carcinoma. Now comes the question of final nail, that is management, right? And the management obviously depends on the cause. Management will depend on the cause, right? And when I talk about cause, right, not all causes, the absolute therapy is indicated. For example, chronic hepatitis B or chronic hepatitis B, there are certain indications. So based on indications, we will start antivirals. If patient doesn't meet the indications, we will not be starting antivirals even if we know that he is a chronic HBV case, right? For hepatitis C, any case is an indication. We would be treating all patients, but for hepatitis B, we have definitive indication, right? So there are drugs to treat the underlying cause. And when the cause is non-treatable or the condition is advanced, we have to think of liver transplantation, right? So when it comes to management, treating underlying cause, and liver transplantation, these are the options. Some of these disorders, you will not only be able to get them a healthy liver, you will be able to also heal or treat the underlying cause, like those metabolic disorders which have led to chronic hepatitis. You will also be able to cure them from the underlying cause when we do a liver transplantation. More on that I have discussed in the liver transplantation video. Okay, so clear, this will be our approach to a case of chronic hepatitis. Now let us look at the individual causes. First, let me start with chronic hepatitis B. Chronic hepatitis B. Okay, so let me begin by first giving you a little introduction to the virus, HBV virus. First point is, among the hepatotropic viruses, this is the only DNA virus, right? So this is a 42 nanometer double-stranded DNA virus. Like, to be more precise, this is a partially double-stranded. That means its DNA at some length has a single strand and remaining portion has a double strand. So it is a partially double-stranded, not completely double-stranded DNA virus. Okay, this is the only hepatotropic DNA viruses among A, B, C, D, E. This is the only one which is a DNA virus. Okay, now there are different genotypes. They are numbered as A to J, but among them they can ask you what is the most common genotype in India and what is the second most common genotype in India, right? So most common genotype in India is genotype D and followed by genotype A. So genotype D is more common than genotype A, and in the northeastern region of India, you do see prevalence of genotype C. Clear? So overall in India, genotype D is most common than genotype A, but in the northeastern states, you might see slightly higher prevalence of genotype C. Okay, now that is clear. With this basic understanding, let us look at the viral structure. Now, understanding the structure of virus might seem like it's more of a microbiology thing, but if you have picturized the image of the HBV virus, right, all its antigens and components, it becomes very easy to interpret or understand the serology, right? So let me take you through the structure of your hepatitis B virus. Okay, as I've already told you, hepatitis B virus is a double-stranded DNA virus. Okay, it under the electron microscope appears as a sphere, so it's a spherical virus. And when you look at the whole virus, right, the whole virus, this particle is called as Dane particle. A single viral particle will be called as Dane particle. An entire virus, all its components, integrity maintained, we call it as Dane particle. So a Dane particle has a layer of surface proteins, which we call as surface proteins, obviously. And it has three types of surface proteins: M protein, S protein, and L protein. And all of these together, we call them as hepatitis B surface protein, or we can call them as hepatitis B surface antigen. Obviously, protein is going to be an antigen, right? Okay, so it is surrounded by, or the virus, the first protein we will encounter on its surface is the surface antigen, right? HBsAg. Okay, now when you look inside, you have another set of proteins arranged as a core, right? We call them as core protein. Core protein, or abbreviated as HBcAg, right? Hepatitis B core antigen. Okay, now inside the core antigen, we will encounter this partially double-stranded. As you can see in the image, it is double-stranded partially and it is single-stranded partially. So we call it as partially double-stranded DNA, and it has polymerase enzyme for the DNA replication. Okay, apart from that, between your surface proteins and core proteins, you have floating proteins, which we call them as E antigen, right, or E protein. It will be called as hepatitis B E antigen. So we have three important antigens. One is surface antigen HBsAg, a core antigen HBcAg, and a HBeAg, right? Now we clearly know that surface antigen is the one which is earliest to be released in circulation. So when there is a hepatitis B infection, the first thing that we can detect is the surface antigen, right? So whenever we have surface antigen, it indicates what? It is equal to infection, right? It says that there is hepatitis B virus infection in the particular patient's body, right? Whether acute, whether chronic, or whether active hepatitis in chronic, or whether it is an inactive carrier state, HBsAg will be positive. As long as virus is there, HBsAg will be positive and detectable, right? So this is the surest evidence of infection, HBsAg presence. Okay, now body might produce an antibody against it, right? So what will we call that antibody as? We will be calling that antibody as anti-HBs antibody, right? Now the point to remember about anti-HBs antibody is that HBs antigen and anti-HBs antibody, they are mutually exclusive. That means when body produces anti-HBs antibody, it will be able to knock off the viral particles. So once you have anti-HBs antibody, it means you will not be any more positive for the surface antigen. It will clear it off. So you will be only be able to detect the antibody against the surface antigen, right? So what does that mean? Surface antigen's presence is equal to infection. So once you have antibody, infection is no longer a concern, right? It is gone. Active infection is not there. Okay, so when that can happen? It can happen when you had a previous infection from which you have recovered, right? Antibody produced, antigen cleared, you have recovered. The second possibility is you have been vaccinated, right? Those are the two possibilities we should think of. So when you say anti-HBs antibody positive, it means either patient has recovered and is no longer active, or it can mean vaccinated patient. How to distinguish between these two, and why vaccinated patients have anti-HBs antibody? Because our vaccines, right, like your Engerix-B, they contain HBsAg, right? Attenuated surface antigen is injected to trigger the immune response. So the response from the body will be by formation of anti-HBs antibody. Clear? Okay, so that is why this will be positive or elevated when the patient is vaccinated, and the patients who had infected, they had HBsAg in their body, and to that body had produced anti-HBs antibody. Now to differentiate between a patient who has got anti-HBs antibody positive, whether it is a recovered case like a remote infection or whether it is a vaccinated case, how do we differentiate? Okay, I'll come to that. Now let us look at the core antigen. So when we talk about core antigen, please remember that it is in the core of the hepatitis B virus and it is not released freely in circulation. So your surface antigen is released freely in circulation but not the core antigen. So core antigen's presence, right, the clinical evidence stems from the antibody produced against core antigen. We will not be detecting the core antigen in patient's blood. Clear? So what we detect against it? Against it we detect anti-HBc antibody. Okay, and this antibody, obviously after the acute initial infection, obviously the predominant antibody form will be IgM, right? So the predominant antibody form will be IgM. Okay, but very soon after the IgM starts getting produced, we will also have IgG being produced. But the point to remember here is IgM will only persist for a short duration after the production. Okay, so like all your acute hepatitis B infections will have IgM, and they will mostly also have IgG, but the IgG is one which will persist for, like, it will generally persist for a very, very long period of time, or it will probably persist to the entire duration of patient's life, right? So it is going to be persistent, though not the first antibody to appear, it is going to be persistent, right? This will disappear soon. So can I say that I can use IgM as a pointer of acute infection? See, IgG is not a differentiator between acute or chronic, because I have already told you IgM is first produced, but pretty soon, right, within few days to weeks, you will also start seeing IgG production, right? So the presence or absence of IgG is less important. More important is presence or absence of IgM. So if the IgM is negative and IgG is positive, that means it's more of chronic hepatitis. But if you have IgM positive as well as IgG positive, or only IgM positive and IgG is not positive, in both those cases, we will start thinking of acute hepatitis B. So IgM is a marker of acute hepatitis B, right? That point is clear. Okay, now coming to the question of anti-HBs positive patients who have recovered versus vaccinated, right? So if it is a vaccinated case, we are only administering the surface antigen. So obviously we'll only have anti-surface antigen antibodies, right? So if patient has only anti-HBs positive, it is mostly a vaccinated case. But someone who has got infected and recovered, if they have recovered, HBsAg will be negative, right? The moment HBs antibody came, the HBs antigen would have disappeared, right? But this IgG is a persistent antibody, right? So if you have an anti-HBc antibody positive, right, which is of IgM type, and patient has anti-HBs antibody positive, it says the patient had a past infection, right? Clear? So we know the profile now. Okay, now coming to the last antigen, that is HBe antigen, right? So what HBe antigen indicates, its positive status indicates that patient is in a replicative stage. Replicative stage, that means there is high infectivity, right? High infectivity. Okay, and also there is higher risk of progression to cirrhosis, because see, please, we have to remember that HBV is not a cytopathic virus. When I say it is not cytopathic virus, it means it is not directly damaging your hepatocyte. So what is damaging the hepatocytes? It's not the virus, it is our immune system, host response. Okay, but higher the replication, higher the viral particles, more virulent will be the host response. So more chances of hepatocyte injury and eventually development of cirrhosis, right? Clear? Okay. Now, will there be an antibody produced against this? Yes, obviously. So we will have an anti-HBe antibody produced against HBe antigen. Again, just like once the surface antigen against antibody comes in, the surface antigen disappears. Similarly, once you have anti-HBe antibody coming in, right, the HBeAg disappears, right? It starts disappearing. Now, what is the relative importance of doing anti-HBe and antibody, right? So doing anti-HBe antibody is that if you have anti-HBe antibody positive and the surface antigen positive, what does that indicate? It indicates that HBeAg is now not being produced, or it is suppressed, right? So that means viral replication is low, right? But you have surface antigen still present. That means infection is still there, but the viral replication is low. Okay, so what does that point towards? It points towards an inactive carrier stage, right? So anti-HBeAg positive and HBsAg positive, both positive, indicates an inactive carrier state, right? Okay, so a lot of this profile based questions or serology profile based questions are possible. So do solve some MCQs, you will get a knack of it, right? Especially if you're in the first year of your MD medicine or DNB medicine, you should spend some time on MCQs solving the serology of the hepatitis B. Okay, so this is the basic introduction to the virus. Okay, so we have understood the structure of the virus, we have the basic idea. Now let us talk about the clinical features of chronic hepatitis, or let me rather say features of chronic hepatitis. The natural course of HBV infection. Now, all the patients who have been infected with the hepatitis B, they are not going to develop the chronic hepatitis, right? So what is the percentage of patients who got exposed to hepatitis B develop chronic hepatitis? See, when you compare the B and C, obviously the chances of chronicity is pretty higher in hepatitis C. The chances of chronicity is relatively less with respect to hepatitis B, right? So when I talk about an adult patient, right, an adult who has been exposed, like there is a reason why I'm starting with adult, right? I'm not talking about children, I'll tell you why. But now, if there is an adult with hepatitis B virus exposure or infection, right, what will be the course? Now, more than 90 to 95% of these patients will recover completely, right? That means there will be no evidence of active hepatitis B virus present in the patient's body. That means when I say recovery, I mean his HBsAg, right? HBsAg is equal to infection, will be negative, and HBV DNA, if you do the PCR, will be non-detectable. That is what I mean when I say recovery, right? More than 90% of the patients are going to get recovered, right? Okay, so remaining patients, like approximately around 5%, right? Like 95-96% patients are going to get completely recovered. Around 5% patients will develop chronic hepatitis. So when I say chronic hepatitis, what does that mean? It means I'm talking about HBsAg being positive for period of more than 6 months, right? Okay, so we'll call it as chronic hepatitis. Now this chronic hepatitis can be of whatever grade, mild, moderate or severe. Depending on that, there will be rate of progression towards the cirrhosis, right? So when there is chronic hepatitis, body is mounting an immune response and that can lead to cirrhosis. So among the patients who develop chronic hepatitis, only few of them are going to develop cirrhosis. From the cirrhosis, there is obviously the risk of development of hepatocellular carcinoma, right? Clear? Okay. Now the question is, what decides the recovery versus chronic hepatitis, right? What is the most important factor that decides the chronicity risk after HBV exposure? Pretty important MCQ indeed, right? So I'll tell you some important data and then you tell me what is the single most important risk factor. So risk of chronicity after hepatitis B exposure, if the age of the individual is less than 1 year, or in other words, it's a infant, right, is more than 90%. Okay, when the age is in the range of 1 to 5 years, it is around 50%. Okay, and for adults or 18 plus, it is less than 5%, right? So we can clearly see that it's the chronicity risk is a function of the age, right? It is dependent on the age. So if there's an MCQ asking you the single most important determinant of chronicity risk of hepatitis B, it is not the exposure load, it is not the route of exposure, no, it is the age, right? So age is the most important determinant of chronicity risk after HBV exposure. Clear? Okay, because very often we would think that it is the exposure route or the exposure load or the load of initial viral inoculation that would be the determinant of chronicity, but no, it is the age, and that is why there is a enormous emphasis on mother to child transmission prevention or vertical transmission prevention, because when the infants or neonates get affected, right, there is a pretty high chance that they will become chronic hepatitis B, right? Adults, the chances are poor. Okay, clear? Okay, so this is about the risk of chronicity. So now that we know that age is an important determinant for the chronicity risk, we should also know what leads to recovery, right? Like even when the age of the patient is under 1 year, 10% of the patients are making a recovery, right? They're not becoming chronic hepatitis. So what leads to recovery? So after initial HBV exposure or infection, so when there is HBV exposure or infection present, right, what antigens are there in the circulation? There are two antigens, right? We have surface antigen, which is now circulating, and we have a HBe antigen because the virus is replicating, right? There is also a core antigen against which the body might produce antibodies, right? Okay. Now, against the surface antigen, the body will produce anti-HBs antibody, and we have to remember one very, very important point about it. So when I say anti-HBs antibody, we have to remember that the surface antigen and the anti-surface antibody are mutually exclusive. Means what? The moment surface antigen starts getting produced and reaches the circulation, the antigen will start going down, right? You will not encounter patients where surface antigen is positive and the anti-HBs antibody is positive. You will see only one of them being positive. Either the surface antigen is positive or anti-HBs antibody is positive. So when you have anti-HBs antibody, it means patient has recovered, right? So the recovery is ensured by producing anti-HBs antibody. So whoever showed that recovery, right, all of them showed recovery because of the development of anti-HBs antibody. Now, those patients who fail to develop anti-HBs antibody, right, the HBs is not triggering the immune response, they become chronic hepatitis. Okay. And once they become chronic hepatitis, those patients will also go through the phases. Okay, those who fail to produce the anti-HBs antibody, as I've already told you, right, they will go on to become chronic hepatitis. And when it comes to chronic hepatitis, that means they will be HBs AG positive, obviously for more than 6 months, and they will be negative for anti-HBs antibody. Okay, now they will pass through phases, like the initial phase where the body is not recognized the particles well, viral particles well, it's not producing any strong immune response against it, and there is an unchecked viral replication, right? That phase, the first phase, that phase will be called as immune tolerant phase. Immune tolerant phase. Okay, and that eventually will lead to the next phase where the body starts recognizing it, and we will call it as immune recognition or immune clearance phase. Okay, now what happens in the immune tolerant phase? Okay, important things we need to know is what is happening to the HBeAg, and is there any anti-HBeAg antibody produced, and what is happening to the HBV DNA levels, and what is happening to ALT. Okay, now when I say that patient has got chronic hepatitis, already it means that patient has HBsAg positive and he doesn't have anti-HBs antibody, right? Now such a patient in the initial phases, when he is in the immune tolerant phase, the virus is not well recognized and it is highly replicative, so it is replicating. So what will happen to the HBV DNA? It will be significantly high, right? So normally a patient who is not infected with HBV, the HBV DNA will be non-detectable. In those patients where it is not replicatively active, it will be less than 2000 international units per ml. But in those patients where it is replicating, it will be more than 2000 international units per ml. And when it is highly replicative, it will be more than 20,000 international units per ml. Clear? Okay, so here it will be obviously most cases 20,000 plus. It's highly replicative phase, immune tolerant phase. Okay, then obviously we already know that EAG positivity means replicativity, it means high infectivity. So that means that it will be positive and it will be also in high titers. Okay, and will there be anti-HBe antigen? No, at this stage, no, right? Once the anti-HBe antibody is produced, right, I should call it as antibody. Once the antibody is produced, slowly it will clear off the HBeAg. So when patient is in immune tolerant phase, obviously there is no antibody production. That is why I say it, right? Immune tolerant, there is no antibody response. So it will be negative. Okay, now what will be happening to ALT? Because we need to know whether the patient is in hepatitis or not. Infection is there, whether inflammation is happening or not. I've already told you that HBV is not a cytopathic virus. So when I say it is not a cytopathic virus, that means it is not directly going to cause hepatocyte injury. It is not directly going to trigger inflammation. It is host immune response which is responsible for inflammation. And we are talking about an immune tolerant phase. So tell me now, will there be elevation in the ALT? No, right? So it will be generally lesser than the upper limit of normal. So it is expected to be normal. Okay, so from here we venture into the next phase, which is called as immune clearance phase. Okay, now what is happening in immune clearance phase? Body is mounting an immune response, but not in the form of anti-HBs antibody. That is why there is no recovery, and also not in the form of anti-HBe antibody. So once the anti-HBe antibody comes in, it will suppress the viral replication. It's not happening. So what is happening in immune clearance? The other immune mechanisms are trying to clear the viruses. So your HBV DNA starts coming down, but it will be still detectable or elevated. So it is elevated, but not as much as the immune tolerant phase, right? The replication is suppressed, but it is still detectable. And your HBeAg will also be still detectable, but relatively less in comparison to immune tolerant phase. And anti-HBe antibody will still be negative. Okay. Now, what will happen to ALT? Right, I have already told you the hepatocyte injury is because of the host immune response. And now we are talking about immune clearance phase. So host has started mounting an immune response. So what will happen now to the ALT, right? ALT will start rising. So ALT will be elevated in these patients, right? It will be more than the upper limit of normal. That is our immune clearance phase. Okay. Now from this phase, what will be the next course for the patient, right? So patient can enter into another phase, what we call as inactive carrier phase. So if body is able to mount a more profound and specific immune response by producing anti-HBe antibody, right? So if you remember, here I said that in both these cases, the anti-HBe antibody is negative, right? Other mechanisms of immune clearance are being employed in the immune clearance phase. But once body starts producing anti-HBe antibodies, it will suppress or clear the HBe antigens. And once the HBe antigen starts coming down, the replicability starts coming down, right? So the DNA levels are coming down, right? So DNA gets suppressed to a point where it is no longer detectable or it is less than 2000. The HBs antigen and just the positive DNA, not quantitatively high DNA, will be the evidence of infection being present, right? And your HBe antigen now becomes negative, right? That is the phase we call it as inactive carrier state, right? So next will be inactive carrier state. So in inactive carrier state, HBeAg will be negative. It is no longer replicative. Anti-HBeAg is the reason for negativity of HBeAg. So this antibody will be positive. HBV DNA will be positive but low. And ALT will be normal because there is no active replication. There is no potent host immune response using other mechanisms which can be damaging to hepatocytes, right? Clear? So we had first immune tolerance phase where HBeAg was positive because the virus was highly in a replicative phase. So DNA was high, as you can see here, 2000 K grossly upper. And ALT, because there is no immune response, the ALT was normal, right? So such a case, if you do biopsy also, you will see minimum or no hepatitis, right? The biopsy evidence will not be there. Then we entered the immune clearance phase. Yes, I have to tell you that this immune clearance phase is also called as HBeAg positive chronic hepatitis B. It will be called as HBeAg positive chronic hepatitis B. So at this stage, because body started mounting some immune response, not specific antibodies, but some immune response, we start noticing the decline in the HBV DNA levels, right? And your HBeAg will be positive, but you should do a quantitative estimation that will also start coming down because the replication is coming down. But because body's immune response now starts damaging the hepatocytes, we will have ALT levels more than the upper limit of normal. This line is representing the upper limit of normal. So we can call it as chronic active hepatitis also, right? That is the immune clearance phase. Okay. Now, if the patient is lucky enough, then this stage will not persist. Rather, he will enter into an inactive carrier stage. Once the body starts producing anti-HBe antibodies, that will suppress the HBe status. So HBeAg becomes negative, suppresses the viral replication so much so that the DNA levels drop below 2000, right? ALT is back to the normal range, right? And this phase is what we call as inactive carrier stage. Okay. Now this inactive carrier stage can jump to the immune clearance phase or the active hepatitis phase. Okay. That's a possibility. And the other possibility is reactivation. Okay. Now what is reactivation? Basically, the viruses will escape. They develop what is called as pre-core mutation. See, the fate of this inactive carrier is either he can become a chronic active hepatitis with HBeAg positive status, or he can even develop a pre-core mutation of the virus and thus lead to what is called as reactivation or HBeAg negative chronic hepatitis B. So again, in both these cases, there will be increased replication again. So the DNA levels start going up. Your HBeAg will be positive if it is the immune clearance phase that he is jumping into, or if it is pre-core mutation that is developing and then developing the active hepatitis, then it will be negative. But ALT will start going up because the immune response also starts damaging your hepatocytes. So this is what we call as either hepatitis E antigen negative chronic hepatitis B or positive chronic hepatitis B. So the fate of inactive carrier is not that he will remain inactive carrier throughout his life. He can remain, many patients will remain inactive carriers. Some of them will switch back to HBeAg positive chronic hepatitis B. Some of them will develop a pre-core mutation and become HBeAg negative chronic hepatitis B. And we have to also remember that the patients who remain inactive carrier, they still have increased risk of developing hepatocellular carcinoma, even in the absence of chronic hepatitis, even in absence of cirrhosis. Clear? Okay. Now this image will probably make it a little more easier for you to remember the phases of chronic hepatitis. First phase is immune tolerance phase. So where you will have a positive HBe antigen because it is highly replicative. Your DNA levels will be grossly elevated, but normal ALT because there is no immune response. HBeAg positive chronic hepatitis, this is what we call as immune clearance phase, right? So in this phase, you will have HBeAg still positive, but the DNA has started coming down, but still detectable. But ALT is now going up because in the immune clearance phase, host immune response is clearing the viruses but also damaging your hepatocytes. Okay. Now once the HBeAg against antibody is produced, that's what we call as HBeAg seroconversion, right? Patient gets into a inactive carrier state when this antibody against the HBeAg makes it negative, right? The antigen becomes negative. DNA level comes down to less than 2000. And your ALT is normalized. This is what we call as inactive carrier. And as this image shows, right, the patient can switch back to chronic active hepatitis of HBeAg positive state, or he might develop a pre-core mutation. And once he develops pre-core mutation, again, patient is back in the active hepatitis. But because of the pre-core mutation, E antigen will not be produced. So he will now have a negative HBeAg, but the DNA will be elevated and the LFT will start becoming abnormal. Okay. Now, this pre-core mutation, we have to remember that these are more highly replicative in comparison to the HBeAg positive cases, and they are also highly infective. Highly infective, right? Okay. Now, this point we have to remember because going forward, when we talk about the treatment, we will be looking at the HBV DNA levels as a criteria. And the DNA levels will be higher for the HBeAg positive status and they will be lower. The cutoff will be lower to initiate treatment for the HBeAg negative patients because of this concern about pre-core mutant variant being highly infective, highly replicative without HBeAg showing up in circulation. Clear? Okay. Now let me get back to the chronic hepatitis B, right? So we have understood about the progression or natural course of the illness of hepatitis B. Okay. Now with this, let us talk about the diagnosis of chronic hepatitis B. So when I say diagnosis of chronic hepatitis B, first thing is there should be hepatitis B infection. So what is the evidence of infection? The evidence of infection comes in the form of HBs antigen positivity, right? Okay. Now when HBsAg is positive, then what will happen to HBs antibody? Obviously it has to be negative, right? So when it is positive, it only indicates two things, either recovery from the previous infection or it indicates vaccination status, nothing more than that, right? Okay. Now infection is proven and we will call it as chronic when it is persisting for more than 6 months, right? That is one point. But what if I'm seeing the patient for the first time, right? Should I wait? Like patient is getting to know his HBsAg status for the first time. Should I wait for 6 more months to make a definitive diagnosis of chronic hepatitis B? No, right? I have to make the diagnosis right now, looking at other serology parameters to decide whether it is acute or chronic, right? So how do I do that? I do that by looking at, so I can establish the chronicity even if I don't have the evidence of HBsAg being positive for 6 months or more, right? I can establish the chronicity by looking at anti-HBc antibody, right? So what will be the profile here? We are talking about chronic. So when I say acute, IgM will be positive, IgG may or may not be positive. In case of the chronic, IgG will be positive and IgM should be negative, right? So I will have IgM. IgM is a pointer of acute infection. So IgM will be negative and IgG will be positive, right? Clear? Okay, so that establishes the chronicity. So let me give you an exercise. Let us see if we make a diagnosis. So the exercise is, here is a profile of a patient who has been first time detected with HBsAg positive. So this is a HBsAg positive individual and his anti-HBc antibody IgM is positive, IgG is positive. So whether it is acute hepatitis or chronic hepatitis, depending on the profile. What did I tell you? Whenever you have anti-HBc IgM positive, it means it is acute, right? In case of chronic, IgM will be negative, IgG will be positive, right? So I have already told you that IgG is also produced soon after the production of IgM, but the IgG persists, IgM disappears, right? So when I see this picture, it is clearly a acute hepatitis B, right? It is acute hepatitis B. Okay. Now, because we're talking about this profile, one more profile, let us see if we can answer, and then we will move on. So there is a patient who is HBsAg negative, anti-HBs positive, and anti-HBc IgM as well as IgG is negative. So what this profile indicates to you, right? This is exercise number 1, this is exercise number 2. Now tell me what this profile indicates. When HBsAg is negative, it means there is no infection, right? But he still has anti-HBs positive. So what does that mean? There is no active infection when I say HBsAg is negative. Past infection is possible when I say anti-HBs antibody is positive, right? But it is also positive in vaccinated cases. So to differentiate between these two, what do? We look at the anti-HBc, right? If anti-HBc is positive, particularly IgG, right, that indicates that patient had an infection and he has recovered. If they are negative, it means patient never had infection, but he still has antibodies. That means we have injected antigen. So we are talking about vaccinated case, right? Someone who has been vaccinated for hepatitis B will give this picture. Clear? Okay. So now we know how to diagnose a case of chronic hepatitis B. Now, once we have made the diagnosis of chronic hepatitis B, next comes the question of management, right? So how do you manage a case of chronic hepatitis B? Okay, before we learn about the indications when to start antivirals, first let us see what are the drugs available with us for management, right? So drugs. What drugs we have? First, we have a class of drugs called as interferons, right? So to be more precise, we have interferon alpha, and currently mostly we use pegylated interferon alpha. Pegylated interferon alpha is preferred because of the better tolerance and higher efficacy. The plain interferon alpha is generally not used anymore. Okay, so that is first class of drugs that we know. And the second class of drugs we can use is nucleoside or nucleotide analogs. Nucleoside or nucleotide analogs. These are the two class of agents we know. Now, before we again discuss the indications, let me tell you that when it comes to hepatitis B virus infection, right, and we are talking about using nucleoside or nucleotide analogs, we prefer using monotherapy, right? So when it comes to HIV, it's combination therapy. Similarly, when it comes to HCV, it will be combination therapy. But when it comes to hepatitis B, we will be talking about monotherapy, right? So we will be preferring to use monotherapy of these agents. Okay. Now, what are the agents that we commonly use? We have drugs like lamivudine, telbivudine. Okay. Then we have drugs like tenofovir, adefovir, and we have entecavir. Okay. Now, among the drugs that I have listed, right, you have to remember that tenofovir and entecavir, right, these are the drugs which are considered as first line agents. These are first line agents. So the other drugs are considered as second line agents or add-ons if the first line agents are showing improper response. Clear? Okay. Now, again, When I say tenofovir, right, we know two forms of tenofovir, right? What are the two forms? First form is tenofovir disoproxil fumarate, which is usually abbreviated as TDF, right? And then we have another form of tenofovir, which is called as tenofovir alafeminide, which is usually abbreviated as TAF and TDF. Okay, now efficacy wise or our experience wise, we have been using TDF for a relatively longer duration of time than TAF. So we have more experience with TDF, and efficacy wise they are comparable or equal. The difference is mainly in the fact that TAF is better tolerated, has relatively more acceptable side effect profile, right? And TDF particularly is associated with increased risk. As such, tenofovir in both forms is associated with increased risk of rapid progression of osteoporosis, but TDF is more so, right? So that's one point we need to remember. So both of them, particularly TDF, carries increased risk of osteoporosis. Okay, point clear? So in elderly 60 plus individuals with osteoporosis, tenofovir should not be considered, or it's like a relative contraindication, I would say. Okay. Now we have another concern with the TDF. The TDF is not a safe drug when it comes to chronic kidney disease. You might consider tenofovir alafeminide when there is decreased GFR. Okay. Now I told you another first line agent, right? Entecavir. The question is, between these two, which one will be the first preferred agent? So please remember, tenofovir is preferred over entecavir. Then where do we use entecavir? So entecavir is preferred in two conditions. So one, when there is a case of osteoporosis, it is preferred, and it is also preferred in patients with chronic kidney disease. So when you have chronic kidney disease, you can think of TAP or entecavir, and when you have osteoporosis, again preferably you can think of entecavir. But efficacy wise, tenofovir is superior, so that is why that is preferred over entecavir. And as I've already told you, it will be monotherapy. So you will be either giving tenofovir or entecavir, not combination of these agents. Okay, now I told you about two treatments, right? Interferon alpha and nucleoside or tide analogs. Between these two, which one will be preferred? For the sake of convenience and cost effectiveness, generally nucleoside or tide analogs, or in simple words, I would say tenofovir is the most preferred drug. But interferon alpha has its own set of benefits and own set of drawbacks. So first, let us look at interferon alpha. So when I say pegylated interferon alpha, right, first thing I would tell is that its advantage is that it is a finite duration of treatment. So when we would use tenofovir or entecavir, right, most patients would require, I'm saying most patients, I don't mean that all patients, we will be able to stop the drug in some patients, but most patients would require indefinite duration of treatment. But when it comes to pegylated interferon alpha, the finite duration of treatment, right, then how long? Generally 48 weeks. The duration of treatment is 48 weeks. So that is the first important advantage. Okay, so I have told you an advantage, so let me tell you a disadvantage. It is administered as a subcutaneous route. Your tenofovir or your entecavir are oral tablets, but this would require a subcutaneous route of administration. Okay, then third thing is, in terms of efficacy, it is less efficacious than your tenofovir or entecavir. In terms of viral clearance, I'm talking about, right? So this is less efficacious than nucleoside or nucleotide analogs. Okay, I hope the point is clear. So it is less effective. So around like 30% patients will show or will achieve seroconversion with the treatment. What do I mean by that? That means that 30% of the patients will develop anti-HBs antibody, and thus they will get cured. So remaining 70% will continue to have viruses in them, right? Okay. Now, what are the other concerns with respect to interferon alpha? Cost. It is expensive, right? So cost is another concern, right? So the advantage is that it is a finite duration of treatment, but the cost is one of the concern. And we should also know that it's effective in patients who are HBeAg positive but still have low baseline DNA levels. Okay, so HBeAg positive with low baseline DNA levels who have elevated ALT, right? That is ideal case for initiation or for the PEG interferon alpha, where we will see the benefit. Clear? Okay, now I forgot to tell you how interferon alpha works. Interferon alpha works by potentiating immune response, right? It is increasing the antigen presentation to the immune system, and that is how the immune reaction gets potentiated, and that is how it will be able to help us clear the viruses, right? Okay, now if there is a question asking you where it is not effective or less effective, and where it is contraindicated, right? So remember, it is less effective in Asian young individuals or young Asians. Why this is important? Because it already means that it's not going to be a great drug when it comes to India, right? It's already costly. It needs subcutaneous administration. Plus, it is not so effective in young Asians. So already for India, it's not a very good drug to start with. Okay. Then the second thing is when there is cirrhosis of liver, it is not likely to be effective. Many patients in India get diagnosed at the stage of cirrhosis, so it's not going to be greatly effective in them, right? And the third thing is it is less effective in genotype D and A, right? So what is the most common genotype in India? D. What is the second most common genotype in India? A. So in both those cases, it's not going to be greatly effective, right? So for that reason, it's not a primary choice for us when we start treating hepatitis B patients. Okay. Now, before we move on to discuss the indications for the initiation of antivirals, we'll also take a quick look at the contraindications for pegylated interferon alpha. What are the contraindications? The first contraindication is decompensated cirrhosis. So as such, it is not so effective in cirrhosis, and when it is decompensated cirrhosis, it's a contraindication. Okay. Apart from that, it is contraindicated in patients with thyroid disease, whether hypo or hyperthyroid. Thyroid disease, it is contraindicated. It is contraindicated in patients who are post-transplant. Okay. And in patients who have severe coronary artery disease, and it is also contraindicated in patients who have psychiatric illness. I'll tell you why. Patients with psychiatric illness. Okay. Now, when you look at thyroid disease post-transplant, do you think any important similarities between these two? What is the most common cause for hypothyroidism in iodine sufficient population? Obviously, it is Hashimoto's thyroiditis. What is the most common cause for hypothyroidism in iodine deficient cases? Obviously, iodine deficiency. But overall, worldwide, what is the most common cause? Hashimoto's, which is a autoimmune disorder. What is the most common cause for hyperthyroidism? Graves' disease, which is again an autoimmune disorder, right? Clear. Now, post-transplant, the transplant rejection is an immune response. The patients are on immunosuppression, right? So I have already told you that the pegylated interferon alpha potentiates immune response. It increases antigen presentation to the immune system. So thyroid diseases, or for that matter, any autoimmune disease, is likely to flare up once they're on pegylated interferon alpha. And there is a high risk of transplant rejection if we put them on pegylated interferon alpha, right? So that's why, remember, it acts by potentiating the immune response, and autoimmune disorders, including thyroid disorders and patients who are on transplanted organs, in all those cases, it is contraindicated. Okay. And then studies have shown that patients who had received pegylated interferon alpha, there is a very high risk of developing major depression. So if they're already a case of psychiatric illness, obviously it will be contraindicated. Clear? So these are all contraindications for pegylated interferon alpha. Okay, just a quick look at the choices. Now, pegylated interferon alpha, as I've already told you, it's not a good choice for India because D and A are the genotypes which are very common. And studies have also shown that it is not so effective in young Asians. And it is subcutaneous and expensive, so not a preferred choice. We will preferably use monotherapy of nucleoside or nucleotide analogs. There are two choices, tenofovir and entecavir. For most patients, tenofovir is preferred over entecavir. Entecavir is generally considered in patients who are elderly with low bone mass density or osteoporosis, or those who have advanced CKD, right? Because tenofovir is known to cause osteoporosis, or it is known to accelerate progression of osteoporosis. So now we have a little bit of clarity about choices. Let us see when to start, right? When to start. Indications for initiation of antivirals. We will see them in two profiles. Indications for antivirals in chronic hepatitis B. We have two parameters, one for the HBeAg positive individuals and one for the HBeAg negative individuals. Right? What are the parameters we will be looking at? We will be looking at the HBV DNA, right? And we will be looking at the ALT levels. Now, why this is important? HBV DNA tells us about the viral replication and ALT levels tell us about the hepatocyte injury. Right? First of all, why are we treating? I have told you it is not cytopathic. So why are we treating? The cirrhosis or liver inflammation is happening because of the host immune response. So why should we treat? The reason we need to treat is the other way of dealing with host immune response against the liver is by doing a potent immunosuppression. Right? Obviously, it comes with its own set of side effects. Or the more logical way of dealing with this is reduce the antigen load. There will be reduced immune response, right? Suppress the viral replication. There will be suppression of the immune response, right? That is how you will be able to salvage the progression of liver disease to cirrhosis, right? So how can we suppress? By using antiviral. That's the logic. So we need evidence of elevated viral replication and hepatocyte injury to start, right? Okay, so in patients who are having HBeAg positive status, okay, we will look at number one, HBV DNA levels, and we will also look at ALT levels. Okay, so when HBV DNA level is more than 20K, when it is more than 20,000 international unit per ml, and ALT level is more than 2 times the upper limit of normal. When it is more than 2 times the upper limit of normal. Okay, I'll tell you what is upper limit of normal. According to American Association for Study of Liver Diseases, for a male, the upper limit of normal for ALT is 35, and for a female it is 29. Okay. Now, various guidelines quote various numbers, but because AASLD guidelines are the most commonly followed guidelines for management, I think it's better to remember these numbers. When it is 35 plus, it will be like 35 will be the upper limit of normal for a male and 29 will be the upper limit of normal for a female. So when I say 2 times the upper limit of normal, if it is a male case, 70 or more than 70 would satisfy, right? If it is a female, 29 into 2, whatever that number is, that will be 58 if my mathematics is right? So when both of these indications are met, right, that is the most definite indication for initiation of antivirals, right? This is the most definite indication. Why this is important? Okay, see, when HBV DNA is 20,000 plus, it means there is active viral replication, and this active viral replication has triggered an immune response. It's right, that immune response is causing liver damage. That is evidenced by ALT level being more than 2 times the upper limit of normal, right? So in all these cases, we should initiate them on antivirals. Okay, now if the HBV DNA is more than 20K international unit per ml, but ALT is more than upper limit of normal, but has not crossed 2 times the upper limit of normal, but it is still less than the 2 times the upper limit of normal, right? In those cases, what should we do? There is evidence of active viral replication, but inflammation evidence is little limited, right? So we need not treat all these patients, only selected cases we will treat. So treat if number one, right, age of the person is more than 40 years and there is persistent ALT elevation. Now what do I mean by persistent ALT elevation? ALT that is elevated for a period of more than 3 to 6 months. Okay, in those cases definitely treat even when the ALT level is not more than 2 times the upper limit of normal, but certainly it is elevated. Right? So treat those patients. Or if you have done the liver biopsy and there is biopsy evidence of significant necroinflammation, okay, or else if you have done the non-invasive assessment of fibrosis and that shows like you have done either the 5-4 or fibroscan and there is evidence of fibrosis, in those cases treat. Okay, rest of the cases you need not treat. Okay, clear. So once I have diagnosed the case as chronic hepatitis B, I will look at HBeAg status. Okay, if it is negative, how do I approach? I'll tell you later. But if it is positive, then I will look at HBV DNA and ALT. HBV DNA is 20,000 plus and ALT is more than 2 times the upper limit of normal. I'm definitely going to start the treatment, right? My choice will most likely for Indian population will be tenofovir or entecavir. Clear? Okay. Now, if the DNA is high, but the ALT is not elevated more than 2 times the upper limit of normal, but certainly elevated above the upper limit of normal. In those cases, selected set of patients we will initiate. When the age of the patient is more than 40 years and where the ALT remains elevated 3 to 6 months down the line, I will consider treatment. Or if I have done invasive or non-invasive assessment, which shows significant necroinflammation or fibrosis, I will initiate medications. Now, what about the other cases? The cases where the HBV DNA is very low and ALT is normal, right? So there is a definite indication for not starting. So for this I told there is a definite indication for starting, right? It's the most definite. There's also a most definite indication for not starting. What is that? Right, so when the DNA levels are less than 2K and ALT level is less than upper limit of normal, right? It's a definite indication for not starting, right? No need for treatment in those cases. Okay, what about the remainder of the patients where the DNA level is more than 2000 but less than 20,000? Right, in those cases they recommend close follow-up because even it is more than 2000 but less than 20,000, the patient may be in a seroconversion stage. Right now, subsequently when you check him later, right, he might turn out to be an inactive carrier. Okay, or he might even get cured, or on the other hand he might also progress to a chronic active hepatitis phase, right? So it is a seroconversion phase, it may be, or it may be actually a chronic active hepatitis phase. So that is why they recommend follow-up every 3 or 6 months or 1 year. We need to start following them up, and anytime they meet the indications of evidence of progression, we will initiate them on the antivirals. Okay, now we have to also remember one extra point here, right? We have to treat patients regardless of HBV DNA levels, HBeAg status and ALT levels in the following circumstances. Okay, number one, when there is established cirrhosis. So when there is cirrhosis, clearly established cirrhosis, you don't need to look at, like, all you need is the positive status for the surface antigen, enough to start antivirals. Okay, in patients with cirrhosis or patients who have developed fulminant hepatic failure or fulminant hepatitis, or in other words acute liver failure, right, there also you don't need to look at, because patient is in fulminant liver failure on a priority basis. This fulminant liver failure is also because of the host immune response, right? Immunosuppression is not the way there. The way is to reduce the antigen load, so antibody load will come down. right? The immune response will get tamed. So we have to think of initiating antivirals. And those who have extra hepatic manifestations. Okay, so then comes the question, what are the extrahepatic manifestations of hepatitis B? One thing we're all familiar is your polyarthritis nodosa, PAN, right? Polyarthritis nodosa. Okay, what else you can expect? Apart from polyarthritis nodosa, patients can develop glomerulonephritis, patients can develop serum sickness like illness, most likely in the acute phase, but sometimes in the chronic phase. Then they can have leukocytoclastic vasculitis. Okay, then they can also have papular acrodermatitis. Okay, they can also have arthralgia arthritis. So if there is an MCQ asking you what is the most common extrahepatic manifestation of HBV infection, your answer should be this. Arthralgia or arthritis is the most common. Okay, now before I move on, one more important point. When we say polyarthritis nodosa, right, is it only seen in hepatitis B patients? The answer is no. It can also be seen in hepatitis C, but more likely to be seen with hepatitis B. And you have to also remember that some of the manifestations that I have listed here, like your PAN, glomerulonephritis, leukocytic vasculitis, right? These are all because of the immune complex deposition. So when antibodies are produced against these viral particles, right, like surface antigen or the core antigen or the E antigen, this complex formed by the antigen antibody, those complexes are not efficiently cleared in some patients, and they get deposited in either blood vessels or glomerulus, right? That leads to development of polyarthritis nodosa, leukocytoclastic vasculitis, or glomerulonephritis. Clear? So if you reduce the antigen load, antibody production will also come down. So the complex production will come down, and thus the complication will less likely happen, or if it has already happened, the progression chances are low. That is why when there is extrahepatic manifestations, you don't need to look at the DNA levels, you don't need to look at the EAG status, you don't need to look at the ALT levels. You have to start them on antivirals. Okay, now this is the story of a patient who was HBeAg positive. I forgot to write here. Okay, now what do we do if the patient is having HBeAg negative status? Right, chronic hepatitis B with HBeAg negative, CHB with HBeAg negative status. Now there are two possibilities when the patient is having HBeAg negative status. Possibility number one, it can be an inactive carrier, right? Or the possibility number two, he might be having a pre-core mutant, right? Now how do we distinguish? Not very important, but just I'm giving you a clue, at least for the sake of exam, right? If it is an inactive carrier, what we would see in an inactive carrier, HBeAg will be negative and anti-HBe antibody will be positive. And when it comes to a pre-core mutant, right, those variants generally will have HBeAg negative, but at the same time they will also have negativity against anti-HBe antibody will also be negative. Clear? Okay, but what guideline says, you don't need to really look at the pre-core mutation. If it is a chronic hepatitis B with evidence of liver inflammation in the form of elevated ALT in an HBeAg negative patient, probably we don't need to stress too much about whether it is the pre-core mutant or inactive carrier. As long as ALT is elevated, right, it is significant. I can't call it as inactive carrier. Okay, so we will look at HBV DNA levels, okay, and we will be looking at ALT. So the indications are pretty similar to what we have discussed so far for the HBeAg positive cases. The only difference is here, because we know that it is more aggressive form, it is more replicative, more infective. If it is a pre-core mutant, we have to keep the lower DNA threshold as the cutoff. So when it is more than 2K and ALT is more than 2 times the upper limit of normal, it is the most definitive indication. No controversy there. Most definitive indication. Okay. On the other hand, if the HBV DNA is more than 2K, but your ALT is more than upper limit of normal, but less than 2 times the upper limit of normal, right? So for these patients, treatment is indicated if age of the individual is more than 40 years and ALT elevation is persistent for more than or equal to 3 months, 3 to 6 months, it is persisting, right? That is one indication. So these indications are very similar to what I have written here, right? If there is liver biopsy evidence of significant necroinflammation, or there is evidence of fibrosis, significant fibrosis on non-invasive tests, including MR elastography or fibroscan or FIB4, APRI. Okay, so in all those cases, we will be initiating the patient on treatment. Okay, so biopsy suggestive of necroinflammation or non-invasive test for fibrosis suggestive of significant fibrosis. So these are all going to be indication. Okay, again I will tell you the same statement that I have told you for the HBeAg positive individuals. When the DNA level is less than 2K, right, it still doesn't rule out the chances of need for treatment initiation, right? We have to remember this statement that I had made, that when it is less than 2K, right, we still need to follow these patients up, right? 3 months, 6 months and 1 year, and subsequently once in 6 months we need to follow these patients up, because this may be indicative of the seroconversion illness, right? And the viral DNA level may go down or may start increasing, so we need to follow them up, right? So less than 2K doesn't mean that we will not be thinking about treatment and we don't need to follow them up. We need to follow them up at regular intervals, and anytime they progress to meet an indication for initiation of treatment, we will be starting. And there are definitely indications where we don't look at the DNA levels, EAG status or the ALT levels, so they will apply for all these EAG negative patients too, right? Because as we have told, right, EAG status doesn't matter. So if there is cirrhosis, HBsAg positive, start, right? Patient with HBsAg positivity presenting with fulminant hepatitis, start, right? Patients with extrahepatic manifestation, even if EAG is negative, start. Clear? Okay, so this is about our hepatitis B, chronic hepatitis. Okay, now we will move to the next important virus, which is hepatitis C, right? HCV. Now when it comes to HCV, chronic hepatitis C, okay, I want you to remember a few important points about HCV, right? When we started talking about HBV, what did we talk about? We know that HBV is a partially double-stranded DNA virus, right? And it belongs to a genus called as Hepednavirus. Now when it comes to hepatitis C, right? HCV is a single-stranded RNA virus. It's a single-stranded RNA virus which belongs to a genus called as Flaviviridae. Flaviviridae. Right. Here also there are genotypes. Instead of naming them with alphabetical numbers, we have used the numericals here. So there are different genotypes. The most common genotype in India is genotype 3. Genotype 3 is the most common genotype in India. Okay, just like hepatitis B, this is also a virus which is usually transmitted through parenteral route. Okay, and it is relatively more common in IV drug abusers, right? And the patients who are going through hemodialysis and professional blood donors. Okay, now when I say that professional blood donors and IV drug abusers, it is very common, there comes a question. If there is a needle prick injury, right, what is the chance of or the risk of transmission when it comes to HIV, HBV and HCV? So, okay, please remember this is like a kind of an MCQ zone, right? So needle prick injury, right? If the patient was HIV positive and some non-HIV positive individual develops a needle prick, what is the risk of developing the HIV infection for this person. If it was an HBV patient from whose contaminated needle the patient is pricked, and if it is HCV, right? Now, between these three, which one has the highest chance of transmission through needle prick? Most of us are really damn worried about HIV, right? But the truth is that it is HBV, which has 30% risk, right? So if there are 100 needle pricks with HBV positive patients and to the like that needle has pricked the non-HBV positive individual, 30 of them will become infected with hepatitis B, right? Remaining 70 may not get infected. But when it comes to HCV, it is 3%, right? So significantly less in comparison to HBV, right? And when it comes to HIV, it is 0.3%. So the numbers are easy to remember, right? HBV there 30%, HCV 3%, HIV 0.3%. Okay. So this is about hepatitis C. It's very prevalent in patients who are on dialysis, who are blood donors, and who are IV drug abusers. Okay. There is a little risk of hepatitis B transmission through breast milk, and it is relatively very low when it comes to hepatitis C. Okay, that is clear. Now let us talk about the viral structure, and then we will understand a little bit about the management of chronic hepatitis C. Okay. Now when we look at the hepatitis C virus, it is an enveloped virus, right? It is an enveloped virus, and it is a single-stranded RNA. So you can see that in the center it has a single-stranded RNA genome, and it has an envelope which has two types of glycoproteins, envelope glycoprotein 1 and envelope glycoprotein 2. Okay. Now within the envelope we have a nucleocapsid, or you can say core of the virus, right, which has capsid. So protein-wise, it has three important proteins: the envelope glycoprotein 2, envelope glycoprotein 1, and core protein. And genome-wise, it has a single-stranded RNA, right? Okay. Now, that is the basic structure. After the basic structure, we need to take a look at the HCV genome. Now, this is important for us to understand the treatment, right? To understand treatment. Now, the genome will code for obviously structural proteins and non-structural proteins. So, what are the structural proteins the genome is coding for? Right, the structural proteins, when I say, obviously there are only three structural proteins that we have spoken about, right? What are those? One is envelope glycoprotein 1, envelope glycoprotein 2, and capsid proteins, right? Okay, so there are three genes coding for these. One gene is called as C gene. The other one is called as E1 and E2, right? Now tell me what C gene will be coding for. Obviously, it will be coding for core or capsid proteins, right? Then E1 will be coding for envelope, E for envelope, right? Envelope glycoprotein 1, and your E2 will be coding for envelope glycoprotein 2, right? These are all structural proteins. Now, when you look at the non-structural segment of the genome, right? We have NS2, then we have an NS3, we have like NS stands for non-structural, right? NS4A, 4B, and then we have NS5A and NS5B. Okay. Now among these important ones, I'm just making a short list, right? NS3 and NS4A, NS5A and NS5B are important for us. I'll tell you why. Okay. Now NS3 and NS4A, right? NS3 is coding for a protease enzyme, right? It is, to be more precise, a form of protein I can call as serine protease. Serine protease. So 3 is coding for it, and your NS4A is coding for a cofactor required for this process. It is coding for a cofactor required for the protease. Okay, now why this is important? Because we can target this, right? We can inhibit this serine protease or its cofactor or both, so that viral replication will get affected, because this protease is very much required for it. Okay. Now NS5A and 5B are two more targets for the treatment. Okay. So viral genome, as I've already told you, right? NS3 is important, which is coding for a serine protease, and 4A is coding for cofactor, so which we will inhibit, and the drugs which inhibit these, right? these protease inhibitor or NS3/4A inhibitors, generally they end with Previr. They end with Previrs. So I can call them as Previrs or those class of drugs. Okay. Now NS5A is coding for viral replication. It is responsible for the viral replication. So we can inhibit this. So the drugs that target this, right, they will end with Asvirs. Asvirs. Okay. And then NS5B, it is coding for an RNA polymerase. So we can also block this. So the drugs that block the NS5B end with Buvirs. So we have Previrs, Asvirs and Buvirs as the class of drugs which are available at our disposal. And Previrs are targeting NS3/4A, Asvirs are targeting NS5A and Buvirs are targeting NS5B. Pretty easy to remember, right? NS5A is being targeted by Asvirs, NS5B is targeted by Buvirs, and whatever is left is Previrs, which is targeting NS3/4A. Clear? Okay. Now we have understood the viral genome also. So let us get back to the HCV. Okay. Now we know what is HCV virus. We know its usual modes of transmission. We know its structure, and we also know its genome and potential pharmacological targets, right? Now let us get back to the infection. Now HCV infection. Natural course of HCV infection. So when there is an HCV exposure, right? Exposure or infection. Right. The question is, what is the chance of chronicity? Right. When it comes to hepatitis B, I told you when it comes to hepatitis B and adults, right? What did I tell you? Age is an important determinant of chronicity, and for adults, right, recovery is more of a likelihood rather than chronicity, right? Like around 5% patients end up becoming chronic hepatitis. Right? Most others are going to recover, right? There is a spontaneous natural recovery because of the host immune response. But when it comes to hepatitis C, right, chronicity is highly likely. The numbers get flipped here. So that is why, like, we are little concerned about hepatitis C. Untreated can lead to a lot of complications. So once there is exposure, okay, less than 15% patients will recover. Okay. Then what about remaining? Right. 85% or more than 85% of the patients will become chronic hepatitis C. Okay. And once they become chronic hepatitis C, obviously there is risk of progression to cirrhosis, right? Around 15 to 20% of them will develop cirrhosis over next 20 years of time. Remaining patients might have mild, moderate to severe hepatitis without developing frank cirrhosis. There will be some amount of fibrosis, but without developing frank cirrhosis. And once there is cirrhosis, obviously there is risk of progression to hepatocellular carcinoma at the rate of 1 to 4% per year. I mean, I'm talking about patients who have developed cirrhosis, not like chronic hepatitis. 1 to 4% per year will develop hepatocellular carcinoma after the diagnosis of cirrhosis. Every year, 1 to 4% of the patients will start showing up with hepatocellular carcinoma. This is the natural course of the illness. So chronicity, I can say, is a rule when it comes to HCV adults, and recovery is kind of a rule when it comes to HBV and adults, right? Okay, coming to the diagnosis of chronic hepatitis C infection. Unlike our hepatitis B infection, there is nothing complicated here, nothing fancy here, right? All we need to do is, the diagnosis is based on, first thing is we have to do anti-HCV antibody, and the method of doing that is enzyme immunoassay. That is a recommended method, enzyme immunoassay, EIA. Now, if the anti-HCV antibody is negative, right, it rules out HCV infection until and unless there are confounding factors present for a false negative result, right? Now, if it is positive, then we have to do HCV RNA PCR. Okay, so if that is also positive, that means there is HCV infection present, right? So when it is negative, we are ruling it out, but if it is positive, we are confirming with the HCV RNA PCR, and once it is positive, right, we have HCV infection. When it is of more than 6 months duration, we will say it is a chronic hepatitis C, right? Clear? Okay. Now we have made the diagnosis by looking at the anti-HCV antibody and your HCV RNA PCR. Then comes the question of management. How do we manage a case of chronic hepatitis C? First thing is, what are the drugs available, and then we will talk about the indications, right? So what are the drugs available? Drugs available include interferon, right? We can think of interferon alpha. Then we have ribavirin. Okay. Then I have drugs like NS3 and NS4A inhibitors. Then I have NS5A inhibitors, and I have NS5B inhibitors, right? Okay, so let me give you examples for 3A. They generally end with previr, right? Glecaprevir, gazoprevir. So all these previrs are your 3 or 4A inhibitors. Now A for asvirs, right? So all these asvirs, velpatasvir, right? There's one example I'm giving you, asvir, velpatasvir, daclatasvir. So all asvirs are 5A inhibitors, and the 5B inhibitors generally they end with buvirs. So these are buvirs, these are asvirs, and these are previrs. So buvirs, one, like the most important drug that we cannot afford to forget is sofosbuvir. Sofosbuvir is a NS5B inhibitor. Okay. Now, I think I have already told you, right? When it comes to HCV infection, combination therapy is the rule. When it comes to HBV infection, we generally start with monotherapy. If there is resistance or failure, we add other drugs, second line agents come into picture, right? Now here, it is the combination therapy. Yeah, I forgot to tell you some important point. Interferon alpha is no longer used. Clear? Okay. Now ribavirin is also not the preferred agent. These are the preferred agents. So collectively we call them as direct acting antivirals, and these are the preferred agents, right? Ribavirin is used in selected patients today. Okay, there is a reason why, right? Ribavirin is associated with, like, when we use ribavirin, it is a indefinite treatment. But all these direct acting antivirals, these are like wonder drugs, right? With this, we will be able to achieve cure, right? Virological clearance and seroconversion with direct acting antivirals, and there is a need for only finite duration of treatment, right? The maximum that we need to do is 12 weeks, not more than that, right? So that is why these are preferred agents. Okay, but I have told you combination therapy, and then the combination depends on the genotype, right? Some combinations work for some genotypes and not for all genotypes. So what we standardly used to do is have a table of what antiviral should be used for the genotype 1, 2, 3 and all that. But the recent guidelines have simplified things. So there is something called as pan-genotypic regimens. So currently the recommendation is for pan-genotypic regimens, where we will be using combination of direct acting antivirals, right? Between previrs, asvirs and buvirs, we will be choosing a combination of 2 or more than 2 drugs. So what are the regimens for which we don't need to look at the genotype? And you have to remember one important point, right? What is the most common genotype in India? That is genotype 3, right? For genotype 3, only pan-genotypic regimens are effective. Like the regimens which will work for all the genotypes are going to work for genotype 3, right? For other genotypes like 1 or 2, there are some regimens which will work on them apart from pan-genotypic, but for 3, only pan-genotypic regimens work. So for the Indian context, it is more logical choice to go ahead with the pan-genotypic regimens. Okay. Now what are the pan-genotypic regimens? Okay, I'll tell you. The first combination you need to remember is sofosbuvir, right? Buvir is which one? NS5B inhibitor plus daclatasvir. So asvir is which one? Which is NS5A inhibitor. So sofosbuvir plus daclatasvir, that is one regimen. Second one is lecaprevir and pibrentasvir. Okay. The third combination is sofosbuvir velpatasvir. So asvir 5A inhibitor, buvir 5B inhibitor, and the last regimen, this you don't need to put too much of effort to remember, which is a combination of sofosbuvir plus velpatasvir. So by this time you already know that this combination is pangenotypic, plus I'm adding one more. The one more that I'm adding to this regimen is oxalaprevir. So this is a combination where there is a previr, asvir and buvir, right? These are the four regimens. Now apart from this, there are like sofosbuvir plus ledipasvir, which is a very commonly used regimen, which is I generally call it as semi pangenotypic. Like it doesn't work for genotype 3 but works for most other genotypes. Now, how do I remember that these are pangenotypic regimens? Because that's the question. That's going to be the question. Like, which of the following regimen is a pangenotypic regimen? How to remember? I'll give you a mnemonic. My mnemonic is, right, you can simplify sofosbuvir, daclatasvir as SD, lecaprevir and pibrentasvir as GP, sofosbuvir and velpatasvir as SV, right? Okay. The fourth one is pretty simple, right? Sofosbuvir, velpatasvir is already a pangenotypic. We're just adding one more there, right? The mnemonic goes like this. Some dedicated general practitioner saves valuable lives. Some dedicated general practitioner saves valuable lives. S saves V valuable lives. Right? That's the mnemonic to remember. Okay, now comes the question of the duration of treatment. So the duration of treatment for one of this regimen is 8 weeks. For most others, it is 12 weeks. Now tell me which one is likely to be 8 weeks. Okay. Now we have one general practitioner here and I can say others are specialists. So who is likely to treat illnesses in a very short, simplistic way? Obviously general practitioner, right? So remember that way, that your lecaprevir and pibrentasvir is for generally 8 weeks. All other regimens are for 12 weeks, right? Clear? So what to know about hepatitis C? Diagnosis is based on anti-HCV antibody and RNA PCR. Indications for treatment, I forgot to tell you, right? I told you about the drugs, but I didn't tell you about the indications. So let me put a slide here. Indications for initiation of antivirals. Pretty simple, guys. The reason I forgot is that all cases which are detected as anti-HCV antibody and RNA positive are indications, are cases for antivirals. So unlike hepatitis B, we don't need to look at the ALT levels and the RNA levels, nothing, right? Indicated for all chronic HCV patients. There are various reasons for that. See, the reason number one, even if you're misdiagnosed in acute HCV, yeah, fine, treat, because chronicity is the rule, right? 85% plus are going to become chronic hepatitis C anyway, right? There is only less than 15% patient getting a spontaneous recovery. Okay, that's number one. Number two, okay, these drugs are damn effective. So when you can cure something, right, why to think about? These drugs are also relatively safe. They're not very toxic drugs. So when they're safe and they are highly effective, better to get them cured, because once the chronicity is established and once the patient progresses to development of fibrosis, then obviously the long journey of complications, decompensation, hospitalization, all that is going to start, right? So better to treat. That's the basic logic. So it is indicated for all HCV patients. As simple as that, right? So the job of remembering indications is now taken away. And also job of remembering complex interferon and drug-based regimens is taken away. Okay. Now I told you that among the drugs available, ribavirin is reserved for selected patients, right? So what is that selected patient? The patients who have decompensated cirrhosis, right? Decompensated cirrhosis. Patients with decompensated. Generally, we add, along with the regimen, we add ribavirin to it. Along with the regimen, we add ribavirin to it. Okay, now one more last point to remember is preferred regimen in patients with CKD, right? Okay, like when CKD is there, better like general practitioner ko bhej do. Yes, so it is the GP or glycopyrrolate pibrentasvir combination is preferred whenever patient is having impaired renal function and you need to start them on antivirals. Okay, clear? So with this, I'm signing off, guys. A brief summary before I sign off. Hepatitis B monotherapy, tenofovir and entecavir are preferred agents. Pegylated interferon alpha benefit is short, finite duration of therapy, but generally doesn't do that good when it comes to Asian young individuals, and it has poor response to genotype D and A, right? So most cases are treated with the tenofovir, or some selected cases where osteoporosis, elderly or CKD, we might lean towards entecavir. When it comes to hepatitis C, current recommendation is to prefer simplified pan-genotypic regimens over the genotype-specific regimens because these work for all the genotypes. And I have already given you the mnemonic. Indication for hepatitis B virus treatment, you have to remember. But for HCV, all patients. And you have to remember which are pan-genotypic regimens for which I have given you the mnemonic. So with this, I'm signing off, guys. I'll see you in the next video module talking about next important topic. Till then, have good times.